Hi everyone, this is Professor Widener recording on Chapter 7, Integration of Patient Preferences and Values and Clinician Expertise into Evidence-Based Decision Making. So this kind of shows in a diagram form what all this means, but basically in English, what this means is that when you're making evidence-based practice decisions, including the evidence that we know, your clinical expertise, and patient values and preferences is what ensures the best quality patient outcomes. And we're going to talk a little bit about how you incorporate patient preferences and values. Throughout the course, we have talked and learned a lot about external evidence. We've looked at different kind of articles and different ways that research is done to make evidence. Your clinical expertise is what you already have and what's based on your practice, and your practice as an RN definitely counts because you learn different things over time, and sometimes it's hard to exactly identify how you know these things, but you do know them. So your clinical expertise comes along with you. But patient preferences and values is also really important because if we don't include those in our decision making, we may have a beautiful plan, but let's say the patient doesn't have transportation to get there, then that is not a great plan for that person because they don't have the transportation to get there. A lot of times, insurance is a limiting factor, and frequently in a rural area where I practice hospital medicine, there are certain things, are the guidelines, which we'll talk about in the next chapter, say that like for high blood pressure, patients should be on X, Y, and Z medicine. Well, they don't have any insurance, so X, Y, and Z medicine is not covered. So again, with something being better than nothing, if you use the Walmart $4 list to help manage their blood pressure, that meets the goal of a quality patient outcome because there's still evidence to support the medicine you're using. You're using your clinical judgment and also including the patient preferences and values. This is something that I think really sets nurse practitioners apart from other providers. I know I work with many physician's assistants and many doctors, MDs, NDOs, and they all definitely care about their patients, but I think taking things a little bit further is something that we learn at the bedside as nurses, and I really think it's one of the things that we do well as nurse practitioners. So in integrating all these things, this is basically like a summary of what I just said, but research evidence needs to be considered in light of any concerns that the patient has or preferences, and that is filtered through your clinical expertise. And these patient concerns could be family, they could be cultural, it could be disease trajectory, it could be history, and also what we're seeing right now related to the COVID vaccine is the reliability and validity of existing research of evidence. There is some right now vaccine hesitancy because of there not being long-term data on the vaccines. So again, when advising a patient, that has to be taken into consideration in making your recommendations. There is a framework for clinical decision making that is called evidentialism. It is a framework for understanding how research evidence and patients' concerns, history, family, and cultural context and disease trajectory are used in decision-making processes to make a plan of care. Disease trajectory means that someone may be in the beginning stages of their cancer, and then you may see them one time in the office in the beginning stages, then you may see them in the middle stages, but then at the end they may choose for a less aggressive method of treatment, and they may choose that anywhere along the way. So again, depending on the exact disease and trajectory, that will influence patient decision-making as well. So the central themes around this framework are that clinicians must find and know the information upon which decisions are made. And that is basically, again, what we've been doing, with decisions being based on current evidence, which means they are based on what is presently known, not even also understanding that that may change in the future. So again, this is why it's so important once you get into practice to read and keep yourself up to date. Like the app Up to Date is actually an excellent way to just refresh your memory and see what is the current evidence, because they obviously do change. But again, all those things need to be considered in decision making. Experiences of the clinician and the patient have had also count as evidence when making these decisions. It comes with several assumptions, and assumptions are things that if you believe in the evidentialism, that you believe these to be true. So that means that one, only decisions that result from thoughtfully responsible behavior are justified. Again, that means that we've incorporated all the parts we're supposed to. Number two, external evidence that supports a conclusion about patient care may not be significant to make a conclusion clinically meaningful. So, for instance, I would use the topic of stroke. So if someone has a stroke, they need to be on a high-dose statin, which is Zocor 80 milligrams or Lipitor 40 milligrams or Crestor 20 milligrams. Now, at those doses, they are covered by insurance, but if you don't have insurance and you need those high doses, and unfortunately, the statins are not really covered by any assistance programs right now, you may need to consider getting medicines from the Walmart list, and they may have Zocor 20 milligrams as part of their list. Well, you get the month's supply of the Zocor to make that clinically meaningful for that patient. So I hope that that makes sense. And as available external evidence changes, you are responsible to keep up to date on that so your responses can change as well. Number four, decisions are made from a set of external evidence based on reliability, availability, and applicability of the evidence, and on the clinician's grasp of the evidence. So what we would call your clinical wisdom, and that comes along with what you've learned throughout the years. I think nurses have a good internal intuition as well, so that becomes part of it, and knowing your patient. And finally, it's having a belief that without supportive external evidence is unwise, and therefore that belief is unjustified. So not only should that belief not impact clinical decisions, it should be not used to make any decisions. So again, our beliefs without evidence should always be factored in. Think of it as like when you're thinking about cultural experiences, we all have certain cultural biases that we need to be aware of so we don't impose those on other people or on our decision-making capacities. So question number one, is the following statement true or false? Evidentialism is the process by which an evidence-based clinical decision is reached solely on external evidence. I hope you're all screaming false. Remember, it's a combination of the clinician's expertise, the patient and family preferences, and disease trajectory. Finally, in talking about patient-centered care, it's a very important part of evidence-based decision making. And as you go through your continue to go through your clinical courses and working through your capstones, you'll see that patient preference remains quite important. And again, I'm not going to read the slide to you, but it goes through, again, some of the things we've already talked about. Patients can have different needs and values, and those needs and values need to guide clinical decisions. They can also have different cultural traditions, values, or personal preferences or lifestyles that need to be considered as well. So if you just remember to treat the patient as the center of all your decision making, along with the knowledge that you have and the external evidence, your goal is to create a good plan that works for them to help their health condition. Just some final thoughts about patient-centeredness. The needs of the patient always need to come first. Nothing about me without me, and every patient is the only patient. Remember, they're not worried about another patient you may have had. This is what they should be at the center of all your decisions. This gentleman, Ronald Berwick, who was a former administrator of CMS, he also proposed such things to patient care. Again, to help improve things are hospitals with no restrictions on visiting. Decisions are made by the patient and or their family, which you have seen implemented over the past few years. Patients determine what food they eat and what clothes they can wear, and bedside rounding. And I know that in the hospital where I work for my clinical practice, visiting non-COVID is not restricted, and there is bedside rounding. They do get patient menu preferences every day, but the preferences are not quite probably as much as they would like. I also would like to talk a little bit about shared decision making, and that again brings the patient's voice together as an equal with the clinician to formulate a plan. So the goal of this is to achieve the best outcomes and empower patients and their families. Communication is two-way between the patient and the provider. It's imperative that both communication and perception of the issues are addressed when making shared decisions, and clinicians need to remember again not to make judgments about their patients based on their expectations or their desires. So finally, question number 2, which of these would be an example of shared decision making? A nurse brings discharge instructions to the patient that is being discharged from the urgent care. Hospitalized patients are provided with a menu along them to choose what they would like to eat for each meal each day. C, the midwife sits down with the expecting couple and holds a conversation about what to expect during labor and delivery, answers all questions, and crafts a birth plan. Or C, the pharmacist asks if the patient has any questions when they go to the retail pharmacy to pick up their prescriptions. So C is the answer. And the midwife actually sits down, holds the conversation about what to expect during labor, answers their questions, and crafts a birth plan. Answers A, B, and D reflect a different paradigm in where patients and families cannot understand and they're not able to participate in the decision-making care. And Berwick stated that this is a little paternalistic, as healthcare consumers are much more educated now and are able to participate in their care, or at least have someone to advocate for them. So I hope that answers your questions about patient involvement in care and utilizing your clinical expertise with evidence.